بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا، إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are now continuing the lecture of hydrocephalus. We have finished with the regular types of hydrocephalus. Now we are dealing with some special types of hydrocephalus, which will include holoprosencephaly, hydranencephaly, Dandy Walker anomaly, and the Chiari malformation. Starting first by the holoprosencephaly, which is a type of hydrocephalus where there is no differentiation into the ventricular system, but in the most common type, which is the A-lobar type, you can see that the ventricles are only represented by a single midline cavity filled with CSF. And based on the ventricular differentiation, we have three types. The A-lobar type, where there is a single ventricular cavity in the midline. The semi-lobar type, there is some differentiation of the ventricular system and differentiation also of the brain tissue into what looks like two separate cerebral hemispheres. And the ventricle may have an occipital hole, but still the most of the ventricular of the lateral ventricles are fused together across the midline, and this is known as the semi-lobar type. In the lobar type, there is almost differentiation of the ventricular system with development of two cerebral hemispheres and two lateral ventricles, showing almost the normal configuration except for some fusion in the anterior part between the frontal horns of the lateral ventricles with absence of the septum pellucidum in between. And you can compare the three forms by the normal appearance of the brain tissue, where you can see the interhemispheric fissure, and you see each lateral ventricle is separated from the other by the midline structures. Then this is the A-lobar type, as I have said, is the most common and the most severe type of this holoprosencephaly. It is usually diagnosed in utero by ultrasound and of course by fetal MRI. There are so many clinical presentations, but commonly you see seizures, you see abnormal reflexes, and you got severe midline facial anomalies with hypothyroidism. And in the imaging, you see, as I have mentioned, that the ventricular system is represented by a single monoventricle, which is midline in location with and filled with CSF. The remaining brain tissue is not differentiated into two cerebral hemispheres, and this arrow points to the region where the interhemispheric fissure should be, and also the falx should be present here, but there is no differentiation or failure of separation of the brain tissue into two separate hemispheres. Then you got a single brain tissue, a single monoventricle, and fused thalami with reduced size. And here you can appreciate this. This is the region of the thalami, and they are fused together and also reduced in size. Then most of the midline structures are not present, including the falx cerebri, the corpus callosum, the interhemispheric fissure, the third ventricle, together with the sylvian fissures as well. They are also absent. And this is an example of A-lobar holoprosencephaly, where you see a single monoventricle with absence of the midline structures, together with the presence also of an occipital meningocele. And this is also another type of, or another example of holoprosencephaly A lobar type, where you see a single monoventricle and there is no falx, no interhemispheric fissure. The basal ganglia are small in size and they are usually fused together. The posterior fossa looks in most of the cases normal in appearance. A third example of holoprosencephaly with single monoventricle and the posterior fossa looks normal. Then the semilobar type, there is partial attempt at brain diverticulation, and you may have the appearance of two cerebral hemispheres, but the the interhemispheric fissure is not formed or not well formed. The ventricles are still fused across the midline with a classic configuration known as H-shaped monoventricle. The ventricle is a single cavity having the H appearance, and there may be development of the occipital and the temporal horns of the lateral ventricles. And this is an example of holoprosencephaly. The third ventricle is looks to be present, but the lateral ventricles are fused across the midline with an attempt to form the occipital horns as well as part of the temporal horns. But the interhemispheric fissure is absent, the falx cerebri is also absent. And this is a less severe form of semilobar holoprosencephaly, where you can see there is part of the falx and the ventricles have the frontal horn and the occipital horn. The third ventricle is present, but higher up you see the ventricles as a single chamber. There is no septum pellucidum and they are fused together across the midline. This is also an example where you see more attempt at the differentiation of the lateral ventricles as well as the third ventricle. The posterior fossa is good. The supratentorial ventricles are fused together, forming a single cavity. The lobar holoprosencephaly, there is almost complete brain cleavage into two cerebral hemispheres and well-lobulated ventricles. They have frontal horn, occipital horn, temporal horn, and body. The interhemispheric fissure and falx are also well formed, and the only thing here is the absence of the septum pellucidum in the between the frontal horns of the lateral ventricles. And in the coronal images, you see this very characteristic configuration of the frontal horns of the lateral ventricles, which is known as the box-like frontal horns. Then this is also a lobar type holoprosencephaly. In the coronal image, you cannot see the septum pellucidum, and you see the box-like configuration of the frontal horns. Then we came to the second type, which is hydrocephalus, and in this disease, there is absence of most of the cerebral tissue, and the basal ganglia are present, the thalami are present, parts of the frontal and the temporal lobes are also present, and the cerebellum is normal, and the falx, which is very important here, the falx should be present. Then you see a huge cavity which is filled with CSF, and the falx cerebri is present. And this one of the ways to discriminate between holoprosencephaly A lobar type and the hydrocephalus. The brainstem is small and atrophic, and there is a large sac filled with CSF, and this sac is devoid of neurons. The wall of the sac is fibrous tissue. There is no brain tissue, and this means that if you shunt this hydrocephalus, the patient intelligence will not improve because the wall of the ventricle is made of fibrous tissue. Also, there is major abnormalities in the circle of Willis with absence of the anterior cerebral and the middle cerebral artery. And this is the hydroencephaly, with the brain is replaced by a huge cavity filled with CSF. The thalami are maybe fused together, and very importantly, you see the falx cerebri present in order to diagnose this abnormality. Then there are a lot of posterior fossa cystic malformations, including the Dandy-Walker anomaly, the Dandy-Walker variant, the megacisterna magna, and the posterior fossa arachnoid cyst. We'll start first. All these patients may present by developmental delay and head enlargement and signs and symptoms of hydrocephalus. Then, in cases of Dandy-Walker malformation, most of these are, of course, of unknown etiology. The posterior fossa is enlarged. This is one of the stigmata of Dandy-Walker malformation. The posterior fossa is enlarged, and there is a big cyst posterior to the cerebellum, and this cyst is connected to the fourth ventricle via the aplasia of the cerebellar vermis. You know, this is the region of the cerebellar vermis, and it's not present, leading to direct communication between the posterior fossa cyst and the fourth ventricle. Consequently, most of the posterior fossa is occupied by this cystic lesion, and the cerebellar hemispheres will be hypoplastic. Then, in order to diagnose Dandy-Walker malformation, there should be a cyst filled with CSF posterior to the cerebellum, and this cyst is directly communicating with the fourth ventricle via aplasia of the verms, and the cerebellar hemispheres will be somewhat hypoplastic, and there may be, and this is not an essential feature, there may be hydrocephalus in the supratentorial area. Then, using MRI in the sagittal image, you know that this is the site of the fourth ventricle, and there should be a cerebellum here. But in this case, you see a big cyst filled with CSF directly communicating with the fourth ventricle. There is no cerebellar vermis, and the cerebellar hemispheres are hypoplastic. Also, the brainstem may be hypoplastic. And this is a good example of Dandy-Walker malformation. There is a big cyst posterior to the cerebellum, and this cyst is communicating with the fourth ventricle through the region where the vermis should be present, but it is aplastic, and the cerebellar hemispheres are hypoplastic, and the supratentorial ventricles are dilated due to hydrocephalus. And these are the associated anomalies with Dandy-Walker malformation, including 75% will develop hydrocephalus by the age of 3 months, 32% will have corpus callosum agenesis, 18% may have an occipital encephalocele. This is an occipital meningocele, does not contain any brain tissue, and 7% may have neuronal migration disorders. I will explain in full details what are these disorders in a separate lecture. Then, as I have mentioned, the presence of supratentorial hydrocephalus is not an essential feature of Dandy-Walker malformation. It is usually present, but sometimes it is not. And here you see the posterior fossa cyst, which is communicating directly to the fourth ventricle with hypoplastic cerebellar hemispheres, and the supratentorial ventricles are not dilated. And there is a variant for the Dandy-Walker, and sometimes it's called the cerebellar hypoplasia, which reflects actually the imaging finding. In this picture, you see that in this disease, you see that the cerebellar hemispheres are hypoplastic. The vermis are more or less present. They're partially hypoplastic, and there is some communication with the between the cyst posterior to the cerebellum and the fourth ventricle. But in some sections, you can see that the vermis is present. And hydrocephalus supratentorially is not usually present, but it can be seen in some cases. Then mild vermian hypoplasia, and you see some part of the vermis. Megacisterna magna, representing the retrocerebellar cyst, and the fourth ventricle is usually normal, and the posterior fossa is not enlarged, and the brainstem is of normal size, as you can see here. Then, and this Dandy Walker variant is a small retrocerebellar cyst represented by megacisterna magna. It is somewhat communicating with the fourth ventricle, and there is some vermis which is present, and the supratentorial ventricles are slightly dilated. Then there is a normal variant where the cisterna magna is very large. Then this is, as I have said, the normal variant. It is the cisterna magna is big, but the vermis is present. The fourth ventricle is of normal size. The supratentorial ventricles are normal. The cerebellum is well developed, and this is known as megacisterna magna. The megacisterna magna is a normal variant, just an enlargement of the cisterna magna posterior to the cerebellum. And one of the helpful diagnostic criteria for the megacisterna magna separating it from the rest of the posterior fossa abnormalities is the presence of these internal septations, which are known as subarachnoid septa or dural folds. And this is not present in the Dandy Walker or its variant or the posterior fossa arachnoid cyst, as I will mention. Then this is the arachnoid cyst. Here you see a big cyst posterior to the cerebellum, but this cyst is not communicating with the fourth ventricle. The fourth ventricle is actually compressed by this space occupying lesion. Also, the cerebellum is compressed by this space occupying lesion. Consequently, you got supratentorial hydrocephalic changes. And here you see a big cyst posterior to the cerebellum, but the cerebellum is good, the vermis is present, the fourth ventricle is almost of normal size, and the supratentorial ventricles are dilated. And this is also a third example of posterior fossa arachnoid cyst, where you see a cystic lesion containing CSF, low signal in the T1, high signal in the T2, and the cyst is not communicating with the fourth ventricle. The vermis is present, the cerebellum is good, but there is supratentorial hydrocephalic changes due to the compressive effect of the arachnoid cyst on the fourth ventricle. And here are the three major anomalies. Dandy Walker malformation, the posterior fossa is large, and the retrocerebellar cyst is directly communicating with the fourth ventricle through the aplastic vermis. The cerebellar hemispheres are hypoplastic, and there is usually supratentorial hydrocephalus. In cases of megacisterna magna, there is a cyst posterior to the cerebellum. The cerebellum is good, the fourth ventricle is normal, the vermis will be present, and the supratentorial ventricles are not dilated. Retrocerebellar arachnoid cyst, there is a cyst which is not communicating with the fourth ventricle, but due to the compression effect, there will be supratentorial hydrocephalic changes. The last one of this group is the Chiari malformation, and this has been reported by Hans Chiari 1891. And this Chiari malformation represents some form of abnormal descent of the posterior fossa structures into the upper part of the cervical spinal canal, starting from the cerebellar tonsil, then the cerebellar vermis, then part of the cerebellar hemispheres and the fourth ventricle, and maybe part of the brainstem as well. And we should know that normally the cerebellar tonsils are below the level of the foramen magnum, and this extent will be large in the first decade of life, reaching about 6 millimeter. Then it decreases by age, reaching about 3 millimeter. Then, if you look here, and this is the cerebellar tonsil, and you draw a line from the occipital bone to the anterior edge of the foramen magnum, then you can see that the part of the cerebellar tonsil is below this line, and this is known as the Chiari one. The Chiari one is not, of course, an anomaly. It may be considered as a normal variant because this descent of the cerebellar tonsils is not usually associated with any symptoms or any other congenital anomalies. What's important is the Chiari-2, and the Chiari-2 malformation represents about 40% of all hydrocephalus in children. And this Chiari-2 means that there is more than of the cerebellar tonsils is descending into the upper part of the cervical spinal canal. Most of these patients will have a small sized posterior fossa because some of the contents of the posterior fossa are now in the cervical spinal canal, and 100% of the patient will have lower back meningocele or meningomyelocele. Then the clinical picture will include difficulties in swallowing, stridor, apneic spells, weak cry, arm weakness, and epileptic fits. Then we have three stages of manifestation of Chiari. Manifestations in the posterior fossa, manifestations above the posterior fossa, manifestations below the posterior fossa. Starting by those in the posterior fossa. Number one, the posterior fossa is of a small size because some of the contents of the posterior fossa are now in the upper part of the cervical spinal canal. Number two, gapping of the foramen magnum, and the foramen magnum is widened to accommodate the descent of the structures coming from the posterior fossa into the upper part of the cervical spinal canal. Number three, concave clivus. The clivus has normally a straight posterior border, and in this condition, the clivus has a concave posterior border in order to add more capacious space to the foramen magnum. And the fourth finding here is the attenuated tube-like fourth ventricle. You cannot usually see the fourth ventricle by CT, but by MRI you can see it, especially in the sagittal images. Then this is the Chiari malformation in the posterior fossa. You can see if you have lower section than this, you can see most of the findings that I have mentioned. Now we will shift to the supratentorial or the changes above the posterior fossa. After that, here you can see the posterior fossa is very small. You cannot see the fourth ventricle, and you see supratentorial hydrocephalic changes. Here by MRI, you can appreciate the changes in the upper part of the cervical spinal canal below the level of the posterior fossa. Number one, you will see the structures coming down in the upper part of the cervical spinal canal, which include the tonsils, the cerebellar vermis, and maybe a small part of the cerebellar hemisphere, but usually the tonsils and the vermis. Then number two, you see elongated tube-like fourth ventricle. You see this is the normal appearance of the fourth ventricle. The fourth ventricle will be elongated and is no more having this configuration. It is tube-like. Number three, and you see the spinal dysraphism in the lower back. You should see a meningocele or meningomyelocele. Then the medulla oblongata, the part of the cerebellum, as I have mentioned, and the medulla oblongata will also descend, and this will result in a kink between the junction of the medulla and the upper part of the cervical spinal cord, which is not usually seen by imaging. Then the supratentorial changes, that changes above the level of the fourth ventricle. Number one, you see hydrocephalus, and this is one of the major manifestations of Chiari-2 malformation. Number two, you see beaking of the dictum. You know that this is the quadrigeminal cistern, and the area in the quadrigeminal cistern of the midbrain is known as the tectum. Then whenever the posterior fossa structure descend downward, then this will pull the quadrigeminal cistern to have a beak-like configuration instead of a gentle curve like this one. Then beaking of the tectum is one of the manifestations. Number two, hydrocephalus. And this hydrocephalus is characterized by one of the major manifestations known as colpocephaly. And by colpocephaly, we mean that there is marked discrepancy between the size of the frontal horn and the size of the occipital horn, which is very big compared to the frontal horn. This is known as colpocephaly. Then hypertrophy of the basal ganglia will indent the ventricles. You know, this is the region of the caudate nucleus, and this is the region of the thalamus. Then these indentations will result in the figure of 3 on one side and the inverted 3 on the opposite side. And of course, agenesis of the corpus callosum is seen in the good percentage of these patients. Also, neuronal migrations can be seen in these conditions, and the fenestrated falx is one of the primary stigmata of this disease. Then what do we mean by fenestrated falx? We mean that there are some fenestrations or holes within the falx, and you cannot see these holes, but you know that they are present by this finding. You can see that brain tissue of the left hemisphere is crossing the midline to the opposite hemisphere, and the brain tissue of the right hemisphere is crossing the midline to the left side. Whenever you see this find, this is one of the diagnostic stigmata of Chiari-2 malformation. And you can say by this mere finding, you are dealing with a case of Chiari malformation, Chiari-2 malformation by the presence of fenestrated falx, meaning that a brain tissue crossing the midline to the opposite side. And here you see that the posterior fossa, the fourth ventricle is attenuated, the beaking of the dictum, the crossing of the brain tissue to the opposite side, and the ventricles are, of course, decompressed by the shunt tube. Then Chiari-3 malformation means that there is some more tissue coming down from the posterior fossa. And this requires that there should be a space for these structures, and this space will be in the form of occipital or upper cervical encephalocele or meningocele. Then you see the manifestations of Chiari-2 malformation plus low occipital or high cervical encephalocele. Encephalocele in this area between the occipital bone and the cervical spinal canal. The contents of the encephalocele, part of the cerebellum, maybe occipital lobes, the medulla, the bones, and the fourth ventricle. And the herniated tissue is, of course, is abnormal. And this is a case of Chiari-3 malformation. You see a very big encephalocele containing brain tissue and cystic CSF space, which is communicating with the fourth ventricle. And this may indicate the presence of Dandy Walker malformation as well. And here is another example. You see, you can call this not Chiari, you can call this encephalocele, occipital encephalocele. But sometimes you may call this an Chiari-3 malformation, where you see an occipital encephalocele or upper cervical encephalocele containing the descended brain tissue. Then some of the literature mentioned that there is a fourth type for the Chiari, and of course it is not belonging to the Chiari because nothing has been descended into the upper part of the cervical spinal canal. Instead, you get severe hypoplasia of the cerebellum. The cerebellum is very, very small, Also, the brainstem is very small. The posterior fossa is mostly occupied by CSF. The brainstem is small. No hydrocephalus. The supratentorial ventricles are of normal size, and no other CNS anomalies. So it is better to call this severe cerebellar hypoplasia, not carry a malformation, but it is included in the literature and under this title. Finally, we have some words about the corpus callosum. And you know, the corpus callosum is a commissural fibers made of four parts connecting the two cerebral hemispheres. And the four parts of the corpus callosum are the rostrum, the genu, the body, and the splenium. And they are formed the genu first, the body second, the splenium third, and the rostrum at last. This is very important because whenever there is agenesis or partial agenesis of the corpus callosum, the finally formed structures will be the first to be aplastic. Then if you look here, this is the normal appearance of the corpus callosum, and this is a case of partial agenesis. You can see the genu and part of the body. You cannot see the splenium and you cannot see the rostrum. And this is a severe type of hypogenesis of the corpus callosum. Of course, MRI is very good here compared to the CT. And you see only part of the genu and the anterior part of the body. Most of the corpus callosum is not present. In the CT images, the clue for the diagnosis of agenesis of the corpus callosum is that you see that the lateral ventricles are separated away from each other from the midline, and they have no configuration. They are stem-like or stick-like. The ventricles have no frontal horn, no occipital horn, no body. The configuration of the lateral ventricles is usually obtained by the presence of the corpus callosum. Then you see straight lateral ventricles that are separated away from the midline because of the absence of the corpus callosum. Then you see here, this is the normal appearance of the corpus callosum, and here you cannot see any traces of the corpus callosum. This is total agenesis. The brain tissue is in direct contact with the wall of the ventricle, and many times you see that the third ventricle is pulled up between the lateral ventricles. This is the third ventricle, which is now occupying the space of the corpus callosum between the lateral ventricle. And sometimes you see the third ventricle at its normal site, and instead then you got an arachnoid cyst in the region of the corpus callosum. And this is absent corpus callosum is better evaluated in the sagittal T1 weighted images, but here you cannot see that the ventricles are separated and the third ventricle is elevated. Then in the sagittal image, you see that there is no corpus callosum at all, and the brain tissue is in direct contact with the ventricular system. One of the lesions that can affect the corpus, of course, it can be affected by many of the lesions like hemorrhage and tumors, and this was to be mentioned in the lipoma of the corpus callosum. Lipoma of the corpus callosum can be one of two forms, the rim form and the mass form. And here you see a high signal lesion in the T1 weighted images, meaning that it is made of fat involving the posterior part of the corpus callosum. And you should remember that lipoma of the corpus callosum may show calcium as well. And this is an example. These are the ventricles which are separated by this fat density with marginal calcification. Fat density or fat signal, high signal in the T1, intermediate signal in the T2, and within the interhemispheric fissure may extend into the ventricles, may show calcification. And it's very important that you know that blood vessels may course through the lipoma. So if it is attempted to be removed surgically, there is some of the hazardous complications. In the T1 weighted images, you see high signal, and the T2 weighted image, you see low signal, and you may appreciate the presence of the vascular structures, and this is a corpus callosum lipome. هذا وبالله التوفيق والحمد لله رب العالمين.